Hello and welcome to Health Policy, Organization, and Finance. This is your Week 4 video. Last week we discussed Medicare. You had a discussion of Medicare using your tools, and you thought about Medicare using the tool of access. I thought everyone did a really good job. We often think of Medicare because it gives healthcare to pretty much everyone over 65 as having really great access. But when you look at it really closely, sometimes there's problems with access, and that could be because of the type of services that it covers and does not cover, weird carve-outs, how much copays can cost, and a bunch of other things that really affect access. So in the first 3 weeks, we've used our tools of cost, quality, and access, and you've already tried those out on a couple of policies. This week, I won't be giving you a new tool because we're using our discussion board to discuss our final policy briefs. Week 4 is about Medicaid. We touch on Medicaid in many other weeks this semester, but this week is really dedicated to it. Just like Medicare, Medicaid was signed into law by President Johnson in 1965. There is a video attached this week produced by Vox, VOX, that gives a good history of Medicare and really why it wasn't originally thought to be this enormous program like Medicare. All states and the U.S. territories, so like Puerto Rico, have Medicaid programs. And those are designed originally to help low-income people. Medicaid is administered by the states, but it has a lot of federal requirements. So unlike Medicare, Medicaid feels a lot more like a state-based program. But keep in mind, Medicaid really grows out of the federal government. The program is funded jointly by both the state and the federal governments. Each pay a portion of the cost. A lot of students say to me, well, what's the percentage? It's different all the time. So you would have to look in your own state because they're all pretty different. I mean, it often ranges more. The federal government often pays more than 50%, but it does pay 50% in some states. So eligibility for Medicaid is, again, different in every state, and the federal government gives some guidelines if they're going to give you federal dollars, that this is what they want you to do as a state, but they do give states the leeway to cover the populations they want to cover. So you might qualify for Medicaid in Maine, but you might not in Massachusetts. You might qualify for it in California, but you might not qualify for it in Arizona. Medicaid is really the biggest healthcare program in the U.S. Right now, I think it's over 60 or 70 million Americans are covered by Medicaid, most often in each state. The groups that are covered are children, pregnant women, a lot of senior citizens, and we'll talk a little bit more about that, and people with disabilities. Federal law requires states to cover certain groups of individuals. So most states you will find that pregnant women who make under certain income limits are covered. But again, that can be different state by state, about whether other family members of a pregnant woman are covered, whether other children are covered. So again, it's really different. States can elect to cover more groups. So a state like California has always really elected to cover a wider group of individuals than a state like Texas, and they are allowed to do that with the federal funding. A lot of you who have learned about the Affordable Care Act probably touched on the Medicaid expansion. The idea was that under the ACA, Medicaid would expand to cover pretty much everybody under certain income limits and get away from that categorical disability, pregnant women, children aspects, and just be based on the federal poverty limit. So that was 125% or 133% of the federal poverty level. You probably have also already discussed that all the states, after the Supreme Court battle, did not elect to expand. If you're watching Maine, that's actually very interesting right now because the state of Maine did not expand Medicaid. However, the voters put through a referendum to expand it. That's been locked up in a court battle for quite some time, so they still have not expanded, but there's a couple other states who their governor and legislature did not expand, but now the people by popular referendum are trying to create a Medicaid policy expansion. I don't want to go too deep into some of these issues, but if you hear that 90%, 100% cost reimbursement, basically under the ACA, if a state immediately expanded their Medicaid program, that expansion was going to be covered 100% by the federal government. And that was a really great incentive for states to really just do the expansion. States that waited now are not covered 100%, they're covered by about 90%. So there's a really complicated topic, and I'm going to try not to confuse anyone, and I'm certainly happy to talk more about it if people want to. But these dual eligibles are one of the more fascinating parts of healthcare policy that I like. Many Americans are covered by both Medicare and Medicaid. These can often be low-income seniors or younger people with really significant disabilities. If you've never talked about dual eligibles before, dual eligibles really are a huge part of the healthcare cost pie. Just because they can be really expensive to take care of. They can take up a lot of the budget. I might find they're a fascinating population to kind of look at. I think, I'm not sure if this was in the text or in one of your readings, but the average for dual eligibles is just below 50% of all Medicaid spending. Probably the most prominent example of a dual eligible would be maybe an 80-year-old who fell and broke their hip and now wants to be living at a nursing home. Medicare does not cover long-term, so Medicaid would cover that, and the patient would also still retain their Medicare to pay for doctor's visits and other things. So, I didn't want to do a discussion post about Medicaid policy because it's different from state to state, so that can be confusing for folks. You're going to be presenting your final paper topics in your discussion post instead, but let's just do a quick look at Medicaid using our tools that we have so far: cost, quality, and access. So the cost of Medicaid, you'll see in some of your readings, is pretty high. We know that it's high because it covers a lot of Americans, millions and millions and millions of Americans. Different states pay different amounts for their Medicaid, but of course different states pay for different things under their Medicaid program. There are different ways to do cost savings under Medicaid, and those can sometimes be called 1115 waivers, where states can say to the federal government, I know this is a rule, however I want to try this, and they can file for a waiver to not follow the rules to try something that might save some costs. If you're interested, 1115 waivers are usually very interesting policy topics, and public health professionals usually keep an eye on them. In regards to quality, Medicaid, like Medicare, comes with a lot of federal regulations, right? So even though it's not government health care, the government gives you a lot of rules about what goes along when they pay you. So just like Medicare, with Medicaid, there's a lot of rules, and a lot of those rules apply to quality. And access is really where you could get lost in Medicaid because it's very different from state to state, as we talked about, and it changes often. So just like a lot of your posts on access to Medicare, I think if we did do a discussion of Medicaid, there would be a lot of smaller things about Medicaid that make us question how much access there really is. So this week, just to point out, there is no textbook reading. The discussion post is a little bit different, and you don't have to use your tools to discuss Medicaid. However, I do want you to think about them throughout the week. And that's it for week 4. Watch the other videos, check out the readings. As always, let me know if you have questions, comments, or concerns. Have a great week. Okay.